Good afternoon, everyone. Good afternoon, yes. Good. I'm Arthur Evans, and welcome. Now, you see this sign that says, psychology makes the impossible possible. So that sounds like hyperbole, right? And I think it may be a little bit of hyperbole. But the point of today's session is to really explore how psychology can be applied to real-world problems, to take on things that people may think are impossible, but really are not if we apply what we know to those issues. So I'm trained as a clinical and community psychologist. I've trained in experimental. I've trained in other areas. And I can tell you, having worked as a case manager, working in inner city parts of New Haven, Connecticut, to running treatment programs, to managing a $1 billion healthcare system, that in all of those positions, I was constantly drawing on my training as a psychologist and constantly drawing on what I knew from the psychological literature. And I can tell you that there were many, many instances where people thought we were dealing with intractable problems, where we were able to come up with solutions based on a lot of the knowledge that psychologists produce. And so today we're going to get an opportunity to talk about some of the challenges of the day, and two in particular, the emergence of artificial intelligence and the opioid epidemic. And we're going to explore how psychology can help address those issues. So if you look at the issues that we're dealing with as a country, healthcare, immigration, gun violence, stress, artificial intelligence, and emerging technologies, all of those are issues that psychologists are working in. Those are areas where psychologists are working. And there's really important information that can help us address those issues. And I really believe that we must ruthlessly apply what we know to these issues. How many of you saw Bryan Stevenson's talk last night? Right? Pretty inspiring, right? Particularly as psychologists. And so I think the challenge for us is, how do we take on some of the issues that Bryan Stevenson talked about and that many of us face? So let me give you an example. The issue of homelessness. If you've been in San Francisco, you know a lot of homeless people here. But if you're in any major city in the country, you know that homelessness is a challenge for most urban areas. And most of us look at that and we think that's just an intractable problem. We'll never be able to deal with and address the issue of homelessness. So tonight I'm going to tell you what the solution to homelessness is. I'm going to tell you how we as a country can solve the issue of homelessness. I want you to lean in and listen carefully. The way we solve homelessness in this country is we get people homes. Thank you. Now, sounds a little glib, but here's the thing. Fundamentally, that is the way you solve homelessness. But most of us know that there are challenges, that many of the people who are homeless have behavioral health conditions. In fact, most people, 90%, either have a substance use disorder or a mental health challenge, but most have both. And so we know that there are barriers to making that happen. But let me tell you how I did some work in Philadelphia with some colleagues there in reducing or getting people who were chronically homeless off of the streets and into homes. And the term chronically homeless is an important term because we're talking about people who had lived on the streets of Philadelphia for 10 years, 15 years, sometimes longer. These people were really having some significant challenges. And how we applied psychological research to address that issue. So one of the things that psychological research tells us is that different things work for different people. That sounds like a sort of simple thing, but I can tell you as a policymaker that most times policymakers want to find a standard solution and apply it to everyone. That's just the way policy works in most instances. But the literature and the research suggests something very different. And so, understanding that, what we did was to create multiple pathways from the street into having a home. So let me give you an example. Psychologists actually in New York did some very interesting work in a model which he calls housing first. How many of you have heard of housing first as a treatment strategy? Okay. So for those of you who don't know, let me tell you how typically behavioral health systems and communities deal with homelessness. The model works like this. We have to go out, convince people to come off of the streets, which, by the way, can sometimes take years and months, get them into treatment, treat them. Once they're treated, do rehabilitation, and then help them get into housing. That's a typical way that people approach that issue. Well, our colleague in New York said, well, what if we just help people get directly off of the streets into housing? Can we do that? Actually, it works. And actually, there's a lot of research that shows that it works. So that was one of the pathways that we created and that pathway works really well for people who have serious mental illness. Doesn't work so well for people who have serious addictions. And I told you that many of the people who are on the streets have serious long-term addiction challenges. And so for those folks, we said, well, if that pathway doesn't work, what does the literature tell us about how we can help those individuals? And so one of the things for those of you who work in the field of addictions, you know, and I think this is also true of mental health, is that the way we've constructed our healthcare system is on basically an acute care model, meaning we go to treatment, we assume that if we treat people and they leave, that they are well. Well, it turns out that addictions, mental illnesses, are more like chronic conditions. It's not like a broken leg, it's more like treating diabetes. But our treatment models aren't set up that way. So when we change our treatment models to match what we know from the science, that is, treat addiction like a chronic condition, i.e. having long-term strategies for engaging people, keeping people into treatment, which costs more money on the front end, but actually saves money on the back end, we actually can get people who traditionally would have come into treatment and left very quickly to stay and to move on to other options. So by using the research, using what we know about how these conditions work, we're able to actually get over an 8-year period about 2,000 people who were chronically homeless off of the streets and into housing. And we did that because we also partnered with people who were doing and funding housing. So I think it's a great example of how using what we know can actually help us to make progress on issues that we think are intractable. So the big challenge is not necessarily that we don't know how to solve problems. The big challenge is how do we connect the dots between what we know and the challenges that our communities and our society faces. Often the people who have the challenges don't understand or know that this information, this knowledge exists, and those of us who are producing that knowledge are often not connected to the people who are in need of that information. And so a big part of our challenge is how do we connect the dots? So let me give you 3 examples of how I think psychology can be impactful in addressing some major issues of the day. Let's take the issue of immigration. We know that from decades of research that separating children from their parents is harmful. From decades of research. And we also know that the longer that happens, the more damage that can happen. And so it was no wonder that psychologists across this country were enraged when we had policies that really flew in the face of what we knew the impact would be on these families. We also know from the literature about how to treat children who are traumatized. We know the stress that is caused from immigration and from being a refugee. We have psychologists who are doing some wonderful work in documenting those issues and documenting how we can treat people and work with people and support people who are experiencing those kinds of situations. And so the challenge for us is to make sure that we're applying that knowledge to our public policy debate and discussion. That's one of the reasons that APA was so involved in that issue. You probably saw, and just by show of hands, how many of you saw a press story or any kind of information that APA was putting out on this issue? I just want to get a sense from the audience. So many of you saw that we were out there making sure that our perspective as psychologists were a part of the public debate on this issue. And I think it made a difference. We were cited by lots of press. We were called upon by members of Congress to do briefings. We were asked and had the opportunity to talk to people in the administration. And in fact, just before I came to this convention, we had the Health and Human Services asking us for our experts to help advise them on policies and practices regarding immigration. So immigration, absolutely an area where I think we have something very important to contribute. We're trying to do that, and we have to look at ways that we can continue to do that. Take another issue that is one of the major issues of the day, gun violence. 100 people a day will die by gun violence. Most of those people don't die by mass shootings. They die by suicide, they die by domestic violence, they die by lots of different ways outside of what the public sees. As psychologists, we know that. We also know the correlates of gun violence, and we know strategies to help reduce gun violence. We also know that we need more research in this area. In fact, there are federal laws that make it difficult to do the research that we need in this area. Do you know that we know more about motor vehicle deaths than we do about gun violence and gun violence deaths? It's by far, it's not even close. And so that's something that we have to change, something that APA is actually advocating on. But when we apply what we know in terms of prevention of violence, prevention of the use of weapons in domestic violence situations, that those are things that we know can reduce both the risk and the mortality associated with gun violence. Now let's give you one last one. How many of you heard the term population health, just by show of hands? A lot of you, most of you, okay? So for those of you who don't work outside of the healthcare arena, one of the concepts that's emerging, and I think will really take off, is the notion of population health. Let me just contrast that with the way we typically address health in the U.S. So our model of health care is based on the idea of the absence of illness is health. So all of our money in health care in the United States goes to treating illness. And in fact, we will spend this year $3 trillion on health care. How many of you knew the number was that big? 3 trillion with a T. And we spend that much money every year trying to treat illness. We spend very little of our healthcare dollar on trying to help people get healthy and stay healthy outside of treating illness. So the idea of population health is, look, even though we spend $3 trillion a year on healthcare, we spend more money in the United States than anybody by far. Our health outcomes are at the very bottom of industrialized countries. And so the idea of population health is, well, what if we had our goal being to raise the health status of of the population, of people that we're taking care of, not just treating illness, but really trying to raise the health status of people. Now, that is good news for psychology, because there is no way that we'll ever be able to raise the health status of Americans without psychology. Let me tell you why. If I were to draw you a pie chart of what accounts for our health status, healthcare would be about 10% in that pie. There's 90% of other stuff. The other stuff being things like environment, genetics, and the biggest part of that pie would be behavior. So if you really want to affect people's behavior or their health status, it has to be through changing behaviors that are related to poor health. That's where we come in. Another major challenge that we face as a society and as a country that really requires us to be an integral part of the solution. So, what's holding us back from making these connections, connecting the dots between what we know and these real-world problems? So I'll give you a couple of suggestions about what that might look like. So I think some of the challenges are us. It's our mental model of what it means to be a psychologist. So I'll give you an example. So when I remember when I was training, I remember this struggle that I was having early in my training as a clinician, where I understood the social, ecological context of the people I was working with. And I knew that as a psychologist, my goal or my role was to treat the illness that people were walking in with. And my mental model of what it meant to be a psychologist required that I ignored the social, cultural context of people and focused on the symptoms of the person sitting in front of me. So for the person who was depressed, who had lost their job, well, maybe somebody else took care of that, but, my job was to deal with the symptoms. When the reality is, I helped the person get a job, probably be a lot better than doing psychotherapy with them. So the point is that sometimes we can sort of limit what we think our interventions are by how we view what our role is. And when we're able to get out of that and think creatively, get out of the box, we're able to bring to bear solutions that we might not otherwise bring. But part of the problem is also how the public sees us. And one of the biggest challenges I think we face is that the public sees what we do as being very narrow, being very limited to mental health. You're going to hear a discussion in a moment about the opioid crisis. And I can tell you, as someone who's worked in that field for 20 years, 25 years, that many of the issues are clinical, but many of the issues have to do more with IO psychology and selection, or they have to do with how we think about messaging or areas of social psychology. So many of the challenges that we face really have solutions that span the whole breadth of psychology. So what we're going to do today is talk to some experts in various areas and get their view on how our field can contribute to some of the challenges that we face. We have three incredible talks that are going to demonstrate this. The first up will be on opioids. And so can you welcome and join me in welcoming Dr. Catherine McHugh and Dr. William Stoops. Great. Thank you for joining us.
Thank you for having us.
Okay, good. So I'm going to start with maybe describing what you see as the problem, and then some of the ways that psychology you think can help address some of those problems.
Sure. I think one important point here is this is not one problem. This is not an opioid use disorder problem. This is not simply a pain problem. There are many problems embedded in this, some of which you just referenced before, things like homelessness. We know that the opioid crisis has particularly impacted areas of the country, even though it's touched pretty much every area, particularly heavily in rural areas, areas with high levels of poverty, areas with poor social connectedness. Not a lot in terms of social organizations where people feel connected to. So this really is many problems, and these problems are all things that psychology addresses, ranging from stigma, which I think we'll talk about a bit, to treatment and clinical intervention, to IO, social determinants of health. It really touches every element of the field.
So I think, the thing that I would add, I come to this as a perspective as an experimental psychologist, and I've said this numerous times. I think of psychology as sort of the original translational science, right? So we are the perfect group of individuals to address this, to help to address. We certainly cannot do it alone. We need to partner with others, but we need to be a big piece of that puzzle to address the multifaceted nature. We need to be thinking about the psychopharmacology. We need to be thinking about, behavioral interventions that we're developing. We need to think about how we train a workforce and how we train a workforce in recovery. And I think that the breadth of psychology, that's the beautiful piece, is we can speak to all of that.
So we just heard that the CDC is expecting the opioid crisis to actually get worse before it gets better. At least the data is continuing to trend up despite the public attention that we're paying to this. So what would you put at the top of your list in terms of what we should be doing to address this issue? If you could tick off maybe 2 or 3 of the top things that we could be doing that you think would bend the curve or help us to bend the curve on this issue.
I think something that's important, if we're talking about, opioid overdose, that's sort of the measure that Americans are using to speak about the magnitude of the problem, and of course it is a huge issue. We have proven ways to prevent opioid overdose or to intervene in opioid overdose. I read that there was an opioid overdose outside the convention center yesterday, and psychologists helped to intervene. So, I think that something that we will need to do is increase access to those overdose prevention, so whether it's Narcan or whether it's having individuals on medication-assisted treatment. And psychology can help bridge those gaps and have that access, and whether it's messaging to the public about, it might be a good idea for you to get trained with Narcan because there's a chance you're gonna witness an overdose. That's something that would be really important to me, I think.
I would say a couple things. One is prevention, which is something that psychology does well and we don't talk nearly enough about. If we can catch someone, if you think of the different touch points along the spectrum of opioid misuse and opioid use disorder, that we know there are certain markers that once you hit that marker, things get a lot worse. So once you go from occasional opiate analgesic use to more regular use, once you start going to intranasal use, once you switch over to heroin use, at each of those points, prognosis worsens dramatically. So if we can catch these things early, if we can catch them in adolescence and intervene at that point, we're giving people a much better option forward. I would say the other thing in terms of workforce development, as a clinical psychologist, we need to be doing better in terms of every clinical psychologist should come out of their training knowing something about addiction and being able to recognize it. I think that's tremendously important because even when the curve does start to bend on opioids, we will have another addiction epidemic of some sort, whether it's stimulants, whether it's something else. So I think that this is an issue both for now and for the future.
So you said something that was kind of interesting and intriguing. So we know that what's driving the current opioid problem is that most people are starting on prescription medication and then they're switching. Sometimes they're switching because their physicians abruptly stop their medication when they find out that they might have a dependency. And then that moves them very quickly into using illicit drugs. Sometimes it's other processes. Can you talk a little bit about how can psychology help address this issue? How can we deal with or help deal with the fact that most people are starting with prescriptions and then switching over to more illicit medications or drugs, actually?
Part of that is better pain management. I mean, certainly psychology is in a fabulous position to support around pain management, behavioral pain management, that in many ways is going to be most effective for chronic management of pain. So starting people at that end is a tremendously large piece of it. But also certainly there are implications at the regulatory level, and how do we think about regulatory changes, and what are the implications of, for example, proposals to limit opioid prescribing. Can we also think through what are the unintended consequences for pain? And what are we going to plug in there? Because if we start taking things away without plugging something else in, that's going to only make this problem worse. And I think psychology is really well suited, both from an organizational perspective to address that, and also from a pain perspective to address it.
I think that's what I was thinking about too. Is the CDC guidelines came out about sort of very short-term opioid prescribing, and I think that left us a little bit in a lurch, because there are people with serious chronic pain who rely on opioids, and we didn't necessarily do something about that. And then we've also got folks who then can't access prescription opioids that they happen to have a use disorder. So you cut off. Kentucky several years ago passed something called House Bill 1. And that was a needed bill to sort of regulate prescription opioids. But the unintended consequence was that heroin then came in and flooded the market. And heroin was laced with fentanyl, and we were seeing overdoses, and we were seeing escalated dependence. And because we didn't come in behind that with increased treatment access, either through behavioral treatment, medication-assisted treatment, and better pain management for those folks, because a lot of those folks start with a legit pain condition. If you don't, I think it's brilliant. If you don't plug something, and if you don't think about actually helping people aside from just cutting off the supply, you wind up with a worse problem than where you started.
So let me give you a challenge that I think we face, okay? So if you look at the research, there's no research that supports the idea of using opioids for the treatment of chronic pain. Public probably doesn't recognize that, right? So that's one issue. And then I think another misperception that the public has, or maybe this isn't misperception, but just not understanding that, one, that there are pain management techniques, and that psychologists are professionals that can help with that. And I want to give you a quick example. So I was talking to two federal officials, high level. I'm not going to mention what agencies they were over, but neither of them, and these are healthcare people, neither of them recognized that psychologists did pain management. So can you talk a little bit about how do we begin changing public perception about sort of the nature of the problem, but also what some of the solutions are, i.e. Pain management by psychologists?
So, I think a great example here for pain management that we're starting to really recognize is sort of the idea of mindfulness, or sort of as a complementary alternative approach to managing pain. And, mindfulness is, has its roots in psychology. And so, we have accepted mindfulness as a treatment for many, many other things. And I think that as a field, we need to show the efficacy of mindfulness. I think we need to do well-controlled experimental studies demonstrating, and there are data, of course, to suggest it, but we need to sort of do the next level up, the bigger, broader scale research, and then also develop a way to then disseminate that to clinicians so that they can adopt mindfulness into their pain management practices. I think we suffer from, one individual does research on this thing, and then it doesn't get carried anywhere. And I think, again, because psychology is translational and it is broad, we are well suited to communicate the findings to each other up the spectrum and back down the spectrum, right? I think that's another beautiful piece, is reverse translation. Take a piece, take something that works, and then take it apart and understand why it works, because then that can help to refine the treatment, that can help to advance our understanding of the brain mechanisms, the behavioral mechanisms that are driving these effective approaches.
Bill, you mentioned the dissemination word, the D word here, which is a tremendous issue, and one in which I also think psychology is really taking a lead in terms of dissemination implementation science. I think that field is growing rapidly and has enormous potential to get the word out there on what does psychology do. I think one of the biggest challenges is, if you are a pharmaceutical company that has a product, you have a lot of reason to go out and market that because you bring that back. If I am a pain psychologist with a shingle, I can't market at a large scale. So finding a way for us to disseminate this information to government officials, and I'm a believer in pull demand. I'm a stubborn clinician. I imagine there are probably also some other stubborn clinicians in the room. I'm a believer that we should be empowering the people who are going to be consuming services to walk in and say, I hear mindfulness is useful. I want this. Do you offer this? And if you don't, I'm going to go to the next person. So I think there's also really an opportunity for us to empower people to be informed consumers and to demand the highest quality care.
What are some other therapeutic techniques that you think we need to be a part of our armamentarium in terms of addressing this issue? So we've talked about contingency management and other strategies.
Sure. So, I mean, something that we were talking about is the idea that, we have pretty effective medications, and, psychologists, I recognize in general are not going to be prescribing these medications. But we also know that adherence to these, to buprenorphine, to methadone, to naltrexone are not as high as we might like them to be. And I think that although a psychologist might not be prescribing that, they can be actively involved in helping folks be better adherent to those medications. We talked about the example of contingency management, which, for those of you who aren't familiar, it's very basic operant principle in that you are reinforcing a behavior that you want individuals to engage in. And lots of time that's abstinence from drug use. That's really how it's been applied in our field. But you can be very creative and apply it for pretty much any target behavior.
Why don't you describe it so that people have an idea of what does that mean? I think we're all psychologists.
Sure. So, so let's say we want our patients to be adherents to the naltrexone regimen, and what you would do in essence is when somebody comes in for their long-acting Vivitrol injection, or when they pick up, if they're on oral naltrexone, which I'm not sure I'm crazy about, but let's say that that's also a treatment modality you might look into, that you provide some form of reinforcer. Oftentimes that's money or vouchers for goods or services. It can be done relatively inexpensively. There's something called a fishbowl approach, where people can just literally reach into a fishbowl and it's a piece of paper that says, "Great job, you showed up and you took your naltrexone today." And that small amount of reinforcement increases the behavior, and it's relatively inexpensive. Still a challenge for many clinics to adopt, but a very effective one. And actually, in the long run, a contingency management approach, because it is so effective, saves you on costs.
The other thing in terms of tools in our toolkit that we haven't talked about yet is supporting families.
Yes.
Which is a tremendous issue. And even if you're not someone working in the area of the field where you're dealing with folks with opioid use disorder, in all likelihood, we're all seeing families that are dealing with it in some ways. And these are folks who are desperate in many ways. They don't know where to send people. And I'll see families at times who have spent $100,000, have emptied their savings, have emptied their retirement to try to support their family members, maybe even ending up in some of these predatory treatment programs, which are a tremendous issue now. So supporting families around how do you talk to loved ones, how do you talk to your kids about substances, I think that's something that really we all can do in a pretty fundamental way and is an important way of impacting this crisis.
One of the things I recognize from my own treatment past is, on this issue of families, is that often we'll take people out of their context, we'll treat them in a treatment program, and then we put them right back into the same context without any intervention. And often the most powerful part of that context is the family. And so, if mom or dad if the children understand how to deal with mom and dad when they are actively using, now mom and dad don't actively use, it actually destabilizes the family. It's like counterintuitive, right? But can you talk a little bit about how you can think about family treatment as a really critical part, an essential part to the treatment of people who are having addictive disorders?
Sure. I mean, the data speaks to this. If you can involve families, outcomes are enormously better. And that is sort of a closed case in terms of how much more effective treatments can be. The challenge is sort of twofold. If you think of the traditional treatment setting, you know, if someone comes in and maybe they work with one of our prescribers and they come see me for an hour, that's maybe an hour and a half of their week. And the rest of their week is full of interacting with friends and family, maybe not going to work, all those other things. So if we can engage the family to reinforce the messages that we're reinforcing in treatment, to be empathic and non-confrontational, to really support people in their recovery, that now you're impacting people where they are. Which is, I think anytime we can make that translation, make that jump, even if I think of as a therapist, my goal is to make myself useless. I want the person sitting across from me to be able to do what I do as soon as possible and not to need me, because if they're implementing that at home, and if they're implementing that with the support of family members, that's tremendous. I don't want them to have to come in and see me. I'd rather that happen.
Mm-hmm. Mm-hmm. So it sounds like that there are some things that we know from the research that could help improve treatment. So you listen to the typical, and I actually chaired a task force in Philadelphia on what the mayor should do around the opioid epidemic in the city. But if you look at most of those task force reports, at the very top of the list is we need more medication-assisted treatment. Now, there's a lot of research support for that. And I'm a strong believer in that. But I think what you're saying is that there are other things that could be just as important. Pain management as an alternative, doing contingency management, treating families, those kinds of things. How do we begin to broaden the conversation so that we include more of these other ways of understanding the problem and understanding the solutions?
So, you know, I mean, I think that psychologists and our colleagues who do substance use disorder research have, you know, worked very hard to develop this evidence base. And, you know, I think that if you go to sort of one of our smaller conferences that is sort of more substance use focused, there's a lot of good work being presented here at APA, but there are also smaller conferences where this is being done. You can see how deep the evidence base is for the interventions that work. I think, again, the issue is that we maybe as researchers have not done as great of a job of communicating that evidence base to the people who can actually implement the policy. And I think that's something that we're starting to do. We you know, the opioid epidemic has created a toehold for us to say, we have been here all along doing this, and look, we've got evidence to show here's what can be used to treat these disorders. And so we now got people listening to us. You know, we now got people who are asking our opinions, who want to engage us. And I think it's a time to really strike and, you know, meet with policymakers at the state, federal level. Another thing I think about is, you know, sort of healthcare, large healthcare plans, insurance plans, engaging those individuals with saying, if you can adopt some of these evidence-based best practices into your healthcare plan, into your HMO, that's a way to disseminate it. You know, they're the ones who are paying the bills, and if you can show it works and it's going to save them money, that's helpful. And again, I think
Well, talk a little bit more about money, because as someone who was a public payer for 20 years, money does. And I think often in our conversations, we have conversations about maybe treatment efficacy and those kinds of things. That speaks to one audience, but I can tell you the audiences that I had to convince were the people who were looking at the bottom line. And so if you're asking me to make an investment in these kinds of things, what kind of data do you have that says that this stuff actually will save me money if I'm paying the bill?
Sure. So, you know, I mean, I think that there are data to suggest that if you have somebody who is on medication-assisted treatment. So if you have engaged somebody in methadone or buprenorphine, you decrease, of course, their likelihood of overdose, which is one thing, but you also decrease their likelihood of acquiring HIV or HCV because they're not injecting drugs, they're not engaging in risky sex. They're, you know, and HIV and HCV are very, very expensive relative to a buprenorphine prescription or a methadone prescription. And so I think the data sort of on adoption of those types of treatments really are compelling to say, you know, yeah, you have to pay for this treatment, but in the long run, you are preventing, and I think we've sort of talked about this, if you can prevent stuff, it's a whole lot better. And you were talking about this in your opening, is that we don't engage in a whole lot of sort of health promotion prevention. We treat things after they're a problem. And yes, of course, you know, opioid use disorder presents itself, then you treat it, but you do then prevent other issues that are very costly.
I think one of the challenges in any kind of cost considerations is for substance use disorders, for mental health in general, you treat it, you save money, society. For substance use disorders, it's even greater. If you look at criminal justice savings for actually treating substance use disorders, it boggles the mind. The problem is who are you talking to in terms of cost savings?
Right.
So a health system might not actually be all that concerned about criminal justice costs. So there's also the issue of where do the costs fall and what audience do we present this to, because the cost savings are tremendous, but they're spread across a number of different groups. Oftentimes they're longer term. And if someone is looking at, you know, what money am I going to save in the next 12 months, that's inevitably going to be more modest. So making that broader case, I think it's a little bit trickier.
Right. What would you tell, I'm sure we have a lot of researchers and clinicians in the audience, what kind of advice or what would you like to say to folks who might be able to contribute to solving some of these problems, challenges?
Sure. So I would say one big thing, you mentioned workforce development. I think anyone who is involved in training, in mentoring researchers and mentoring clinicians, my goodness, do we need to make folks more comfortable with this issue? It's like with any other issue. If you don't see it, you're afraid of it. And I think opioids in particular is one that people are terrified of. I hear all the time from people, they say, I don't want to ask the question. I won't ask whether or not someone's misusing. And when I say why, the answer is 100 times out of 100, I don't know what to do if I get the answer.
Right.
So I think workforce development and encouraging people, and not just in clinical, but in any discipline, to think about this issue. If we can get training in addiction broadly across all of psychology, if this can be really standard in how we think about things, I think that will advance research agendas, that will advance public policy agendas. I think that's enormously important. The other thing I would add is we are all responsible in some ways for stigma. Is if we think about the language that we use, the language that we expect other people to use, we can make a difference in that. And I think that's something that everyone can do today. That's pretty tremendously important.
Yeah, I mean, I completely agree that, you know, one of the things I most admire about APA is that it, you know, it thinks about social justice and it thinks about how we treat people, and it, you know, the idea of person-first language, APA is a leader in that. You know, when we go, you know, I was at an addiction conference in June, and actually I should say a substance use disorder research conference in June, and some of the language that was sort of used in terms of, you know, talking about people as addicts and those kind of things, I was fairly appalled, because I'm thinking, we are the specialists, this is us, and we should not be talking about it in this stigmatizing way. Yet at APA, we don't have that problem as much. And I think that's really an important thing, that we need to think about the stigma and what we are doing. You know, we were talking earlier about, you know, maybe messaging. And so I think one thing I would say is we need everybody. You know, you may not think of yourself as a substance use disorder researcher, but you probably have something to offer if you're a psychologist. You know, these are behaviorally defined disorders. Psychology is about behavior and is about rigorous study of behavior and about behavior, you know, changing behavior. we need your help. We need your help with how we message things. We were talking about, I don't know if anybody has seen them, but the ads where people engage in self-injurious behavior to get the opioids. I don't even know who's putting those out, but they're on in Kentucky. I imagine they're sort of a national ad campaign, and then they close with sort of a slide that says, if you use, basically, this may not be an exact quote, but using opioids even 5 times can, turn you into an addict, is sort of what the language says. And that is not, I think psychology can help people do better with some type of prevention message that isn't fearful, that isn't stigmatizing, and we need everybody's help to do that.
I've heard you all talk about incorporating peers into the treatment process. Can you talk about that and why you think that's important? And let me preface it by saying that I have heard conversations where people have, in our field, have felt threatened by people who don't have, quote, formal professional training.
Sure. So, I think the use of a peer navigator is really valuable, and I've never thought of engaging peers as something that's threatening to a psychology or psychologist. I think of it as an addition, and as a valuable addition, because what I think a peer can do is present someone who is positively in recovery as something that somebody can look to as that they can attain. Not all psychologists are in recovery, and we talked about maybe not all psychologists are even trained to talk about these issues. But a peer who is successfully in recovery can model that and can speak to that. And I think that there's real value there above and beyond what psychologists can do. Now, we were also talking about hiring some of those individuals into, healthcare settings can be challenging. We have to do a lot of education with HR, for example, about, a peer probably doesn't, look like who you might typically hire at a major academic medical center or within a healthcare system, but they can provide real benefit, and so you just have to sort of educate and make sure that everybody's on the same page about why it's important to do this.
Mm-hmm. Mm-hmm.
Yeah, one thing to add to this from a research perspective, and you talk about sort of bringing in peers, recovery coaches is something that has really taken off, and you mentioned sort of the research and policy being able to communicate with each other. And this is one that actually makes me a little bit nervous. And this was one of the White House Commission's recommendations, and it's something in Massachusetts where I am, where I think we're putting the cart a little bit in front of the horse with this one, where recovery coaches in many ways, so these would be peers who can support folks, again, sort of outside of the traditional treatment setting. Someone who might help somebody get to appointments, somebody who might be able to help folks through a high-risk situation. Tremendous potential here, almost no research on it, almost no regulation on it, almost no training available on this. So this is one where I actually think we need to be doing the research, we need to be working with policy to make sure that how are we thinking about some of the challenges? You had mentioned before this issue of what do you do if one of your peers or one of your recovery coaches relapses themselves? Mm-hmm. And how do you think about those kinds of challenges and keeping the peers safe at the same time? So I think there's tremendous benefit here. I think there's also tremendous research gap that really does need to be addressed and hand in hand with these policy changes. Mm-hmm.
What are some of the other areas of research that you think we need to really bolster?
Well, I'd say we talk about medication-assisted treatment and contingency management and psychotherapy working, and I think working absolutely, but working in the same way that a lot of our other treatments work, which is we tend to cap out at sort of a 50% treatment response rate for pretty much anything. We don't do much better than that, and we have to do better than that. Mm-hmm. So I think we have great treatments, not nearly enough people can access them. We need to get them out there. We need to work with what we have. But I think another big research push needs to be, how do we get that 50% even to 60%? How do we maybe get it to 70 or 80%? Some of that I think is prevention. Can we sort of slow that pipeline so there are fewer people who need active treatment? But some of it is also, how do we engage better behavior change strategies? How do we get people medication compliant in a way that we can get above that? We're so stuck at that 50% response rate.
Yeah, I agree. It's so disconcerting. The best we can do a lot of the time is 50%. That's why I was thinking about adherence, because I think some of that is also people are just not necessarily adherent to the treatment and so it's not going to work. Something that I don't think we've talked so much about yet here on this stage is sort of what more basic research, basic psychological research can do. I think that we have really, really smart psychologists who are doing research with rats and monkeys, looking at psychopharmacology. So, as new medications are coming online, either reduced abuse potential pain medications or novel treatment medications, psychologists have been integral to all of that work. To identifying, is a drug going to have abuse potential? Is it going to potentially be effective? And I think that's important too. I think that making sure we don't forget about the basic end, that bringing that piece of science in so they can inform us about what we might want to advance or what we might not want to advance, how we might think about sort of individual differences. I think that a lot of that basic research and controlled human laboratory research can speak to individual vulnerabilities of, this might be a person who is more likely to progress as opposed to somebody else, or some underlying behavioral mechanism. If they're engaged with peers, or if they're engaged with a social network that uses drugs, there's really nice animal models of that can speak to that. And I think that when we're thinking more about the clinical end, we forget about the important value that more basic side adds to it as well.
Mm-hmm. Do you want to say anything else about some of the research agenda and some other areas that we might want to pursue?
Sure. I would say, just to comment on briefly, again, I do think stigma is an area where we could do more research. Both, again, this is an issue where the disease is stigmatized and the treatment is stigmatized, and I think research...
And the treaters.
And
I think we have to think about that many people don't want to get into this field because you become stigmatized as much as the people who we're treating.
I think that is a tremendous issue. And to sort of circle back to some of the social components of this, one of the things that we found in some of our research is one of the major barriers to people engaging in treatment and getting better is if their entire sense of belongingness and their entire social system is embedded within substance use. Mm-hmm. If multi-generational family substance use, where all of somebody's peer, I will never forget, one of the first people I ever worked with clinically, we were talking about her getting back to work, and I will never forget this. I'm just learning at this point. I have no idea what I'm doing, and she sits across from me and she said, look, if I told you to go out on the street and cop, Percocet and some Klonopin and to try to do this without any money in your pocket, you would have no idea what to do with yourself. She said, this is what I feel like with you telling me to look for a job. And I think that is something where we really do need to be looking at some of those social considerations and working with folks around. If we pull off the substance without changing some of these social components, it's not going to last.
Yep.
It's unsustainable.
That's great. So last comments, what's sort of the takeaway you'd like the audience to leave with on this issue?
So, I think that psychology alone is not going to solve the opioid crisis, but psychology, whatever term you want to use, needs a seat at the table, needs to be in the room, and without it, without thinking about psychological aspects of opioid use disorder, of drug use disorders, any intervention, anything you try to do, I think is going to fail, because we think about things that physicians don't think about, that social workers don't think about. And again, but I think we need all of those people. We need all those people because we all bring an important perspective to this. It's such a big, multifaceted problem.
I would say my take home is be both hopeful, and I think there are some indicators, there are some positive indicators that opioid use is dropping in adolescence. I think there's a lot of reasons for hope, and there's a lot of reasons to say we have a long way to go. And I think for both of those reasons, this is an all-hands-on-deck issue, that regardless of what your subdiscipline is within psychology, we all have a role to play. And I think that trying to get engaged in this is something that we all can do. Again, even if you're not in a substance use disorder specialty setting, we can all play a role in this, and I hope that this gave folks some ideas for how you might do that.
Can we give Dr. Stoops and Dr. McHugh a big round of applause and appreciation?
Thank you so much.
Thank you. Thank you.
Thank you.
Good.